Welcome to our lecture. Today we're going to be discussing surgery in the elderly, specifically frailty, geriatric surgery, geriatric syndromes, and us as physicians. My name is Michael Zenilman. I am the Chief of Surgery at New York Presbyterian Brooklyn Methodist Hospital, Vice Chair and Professor of Surgery at Weill Cornell Medicine. I am also a graduate from 1984 of SUNY Downstate's Medical School and was the Clarence and Mary Dennis Professor and Chair of the Department of Surgery from 2000 to 2010. So it is really a pleasure for me to come and to give this talk. I'd like to thank Dr. Reinhardt and all of his group from the Bridge program at SUNY Downstate who really made this important series possible. It's very pertinent, important, and really part of our future. For my disclosures, I am a board member of the Academic Medical Professionals Insurance and Risk Retention Group. This is actually a Downstate and SUNY malpractice corporation, which I got involved with when I was here. I'm a consultant for the Mohammed Anobed Al-Mullah Group of companies in Dubai, where we are consulting for a hospital, the American Hospital in Dubai. Actually, one of our old downstate residents is a professor and chair there. And I'm a peer reviewer for UpToDate, the online and written, semi-annual or serial of articles. The learning objectives today are really a review of historic risk stratifications for surgery in the elderly patient and where we are today. Importantly, identify the new concepts of frailty and geriatric syndromes with our patients, and how the evolution of specialized geriatric surgeries has come and it will and in the future. And at the end, we will discuss the American College of Surgeons Geriatric Verification Program, which is growing nicely, and a short discussion of palliative care, which, while short, is actually becoming more and more important in the surgical field. I'm proud to announce we now have 3 editions of our book from Springer-Verlag, the Principles and Practice of Geriatric Surgery. We had the first edition came out when I was here in 2000. Second edition came out in 2010, and the third edition in 2020. It's with Ronnie Rosenthal, who's a professor of surgery at Yale and is actually a downstate graduate as well, and Mark Catlick, who until recently was the chief of surgery at Sinai Hospital in Baltimore. It's really a wonderful compilation of articles and important information on geriatrics in every field of surgery, from basic science to every subspecialty. So you don't have to buy it. It's in your library, but really it's a great book to have. So geriatric surgery as a field is actually fairly young. This is just a slide I like to show of PubMed searches of these phrases: surgery in the elderly, surgery dementia, surgery delirium, surgery and frailty, and you'll see that there was an exponential rise in peer-reviewed publications on PubMed since really the age of 2000. So it's only a field that's about 25 years old. The first article of geriatrics in surgery was in the 1930s. By a surgeon named Oliver Smith, where they defined geriatrics as anybody over the age of 50. Fortunately, now it's anybody over the age of 65, 70, or 75. It really depends on who you read. But it really is a evolution of a very important field, and most surgeons will tell you that it's not really a field because we're all taking care of geriatric patients. These are a number of publications which are important over the last 25 years, showing frailty as a predictor of surgical outcomes. The lead author here is Marty Makary, who is a surgeon at Hopkins, but as you may now know, is the commissioner of the FDA. And Dori Segev is a transplant surgeon. Peter Pronovost is a world leader in surgical safety and hospital safety now. And then this one is about too frail for surgery. And Tom Robinson at University of Colorado really put the nail in the wood about talking about frailty scoring and frailty as a predictor of postoperative outcomes. And these are really classic publications. In the beginning, I want to just talk about the old school versus the new school of how we dealt with elderly patients. Before really 2000, the old school really was comorbid illnesses in the heart with cardiac, pulmonary, kidney and renal, and diabetes mandated or directed the complications you would have in surgery. And this is from the American Society of Anesthesia publication showing if you have 0 comorbid illnesses in each of these age groups, the risk of surgery is really not related to age because it's a very small slope. So age as a risk factor is not really the core. The core in this old school thought is that the comorbid illnesses, which are cardiac disease, pulmonary, renal, diabetes, direct the complications. So you'll see the more of these complications that you have, the higher your postoperative mortality rate. And it's an exponential rise for each additional disease organ. And that's really how we looked at it. And frankly, it works. This is the American Surgical Association ASA classification. It's even simpler than that. ASA, and it's currently used today. ASA 1 is a healthy patient. ASA 2, 3, and 4 are really incremental illnesses of patients, and it's like anything else. The more sick you are, the more complications you have. And there really was no difference between young patients and older patients with these classifications. The sicker young patients did just as poorly as the sicker old patients, and the healthy young patients did just as well in surgery as the older patients who were not sick. And to this day, whenever you go into the operating room, and hopefully you won't, the anesthesiologist and the surgeon will agree on your ASA score before the surgery. And in fact, it helps direct how we're going to do it. It helps direct how we're talking to patients and their families. And it helps in terms of the risk stratification for the hospital. Here's a very good example of this from 1980. This is a classic article in Annals of Surgery by Boyd showing that as we get older, if one has a colon operation, the mortality rate increases slowly, and once we're over 80 years old, it goes up to 17%. And the mortality rate between 50 and 70 really isn't much different. Same thing with the morbidity rate, although it doesn't really look as much of an increase. And so for the inference from this was, well, if the older you get, the more risk you have for mortality from colectomy. But really, was that true? The answer is no, because if you took out comorbid illnesses or concomitant diseases, the patients who were less than 70 who had 0 or 1 comorbid illness compared to the ones older than 70 had very similar mortality rates. There really is no statistical difference between 0 and 1.5% mortality. But if you were older and you had 2 or more morbidities, you had a higher mortality rate. And certainly if you were younger and you had 2 or more morbidities, you had a higher mortality rate than those who were not as sick. So the comorbid illnesses in this old school of thought was really important, and this made a lot of sense. So how do you improve outcomes using this concept? Get perioperative control of cardiac disease. Remember the Goldman criteria and other criteria to control, bring down the risk stratification of your heart disease. Do preoperative respiratory teaching, renal optimization, control, very close control of your blood sugars, and don't do emergency surgery. The fact is that if you convert an emergency operation into an elective one, the morbidity and mortality is better. But if you need to do the surgery, understanding that it's important, that needs to happen, the mortality rate can be higher. In the new school of thought, we have things called geriatric syndromes, which we'll talk about. We will define frailty. And these are kind of related to the comorbid illnesses, but I'll show that it's more of a structural concept that we have, that people get when they're aging. And that affects outcomes. This is a great example of 2 patients I operated on a number of years ago. On the left is a colon cancer. So both patients have a colon cancer found on the right side. So this patient is 44 years old, has a healthy female, no comorbidities, and runs the business on her own. This patient was a 86-year-old but frail female. She had walked with a walker. She had a number of illnesses. She had a past history of C. diff colitis, had a hip replacement, and both underwent the not simple, but relatively straightforward right hemicolectomy on a Monday. Actually, the two of them, I think it was one Monday one week, another Monday on the other week. The healthy female had a pathology of a stage 1 cancer, which is good. Woke up, walked on the same day, ate on Tuesday, went home Thursday. Nowadays, they actually may go home on Wednesday or even Tuesday, and she was back to work on 10 days. My frail 86-year-old, who is a very sweet lady, had same pathology, woke up, walked a day later, and ate 2 days later and looked like a peach. She looked really great and was doing very well, and I was very happy. But by Saturday, she developed what's called the paralytic ileus. Her bowel went to sleep for a variety of reasons. She developed congestive heart failure, pneumonia, ICU, intensive care unit, and needed parenteral nutrition because she was unable to eat. Ultimately, went home after a couple of weeks and went to rehab 30 days later. So she was in the hospital for a number of weeks and got discharged from rehab about a month after that. And I saw her about 2 months after surgery, well after I saw the first healthy female, and her first question to me was, when can I drive? So even though the patients are frail, they still think they're young and they want to do what they usually did before the operation. Scary thought, but it's real, and I'm sure everybody in this audience has had a relative in this sort of situation where you wonder, when are we going to take the keys away from grandpa or mom, and how do you do that safely? And sometimes we do, sometimes we don't. So frailty is a factor, but really isn't very obvious, and that's why we want to define it better. Laparoscopic colectomy is safe in the elderly. This was an article from 2003. This is in the early days of laparoscopic, minimally invasive surgery. And the article showed that there was no differences in the morbidity and mortality in young versus old, but one thing that came out of this article, which people weren't expecting, was the discharge disposition. What happens when these patients got home? And the patients who had laparoscopy had a better postoperative independent course than those who had open surgery. So not only is laparoscopic surgery safer and give better results than open surgery, it actually gives us a better quality of life. And that's obviously not because we're better surgeons in the laparoscopic age, but because the laparoscope gives us 3 or 4 little incisions, whereas the open surgery is a long incision which you have to recover from. So you can go home easier after a laparoscopic operation. And in this article, 98% of the patients who had laparoscopic surgery who were old went home versus 82% who went home. The others went to a rehab facility and maintained independence at the time of discharge. The survival rate, the readmission rate, complication rates were the same. So it's not so we have to change what we look at with these elderly patients, not just how are you surviving the operation, getting out sooner, but what's your quality of life after surgery? And laparoscopic surgery here showed better independence, which is a really important indicator. And this was actually, we'll show, was resulting from or directly related to your frailty index. This was an interesting article that I did a long time ago now, where we looked at 80-year-olds, octogenarians, who had elective or emergency surgery. And we were not surprised by these outcomes. There were 41 elective cases, 21 emergency cases. Length of stay after the surgery was not really different. The length of stay in the ICU, the length of stay in the hospital, the complication rates really weren't changed. The 33% mortality rate of an emergency surgery for colon surgery has not really changed in the last 40 years. So that's where I said before, it's the emergency operations. If you can convert things into elective operations, it makes a hell of a lot difference for the patients. But more importantly, what we found here, which was new at the time, was independent living. Patients went home after elective surgery 83% of the time versus only almost half of that for the emergency operation.